Respected Dr. Ziad and other friends here. Basically, I need to take you all through vessel analysis and device sizing with OCT. I think with the discussions already, some preamble was set in. This was shared by Nikhil Prachure, so let me skip this. Right, this is how OCT looks like a normal artery. There is a closer to the lumen, there is a signal-rich area. Then in the middle, there is a signal-poor area, followed by in the outer, again a signal-rich area. One should concentrate on this middle signal-poor area where it is closer to the intima, you call it as internal elastic lamina, and closer to the adventitia, you call it as external elastic lamina. And we are all interested about EEL, which was popularized by Illumian 3 based stenting is really changed the way we size the stenting. So the beauty of OCT over IVUS is definitely the automation. Automatic lumen area and automatic lumen diameter and automatic area of stenosis and artificial intelligence along with automation. Even with the high definition IVUS today available, they are still struggling with automation. Again, compared to IVUS, OCT-derived MLA had a superior specificity and diagnostic accuracy for the detection of hemodynamically significant lesion in a meta-analysis of 7,000 patients for an FFR of less than 0.80. And this algorithm, MLD Max, which Ziadari was discussing just now, was very useful, very simple algorithmic approach. Workhorse can be practiced by everyone in any lab. The morphology is the way to start with. For example, if you take a morphology being a calcium, then a calcium volume index score. If OCT comes up with the automatic CVI score, it's one step, it will be further. And when morphology is characterized, then you get away with the preparation depending on the morphology. Then comes the length. That the middle panel or the automatic lumen profile, which I am going to show you in one of my case, will volumetrically automatically picks up the proximal and distal landing. And once the machine picks up the automatic proximal and distal landing, now we are going to do the EL based and block burden based, MLA based adjustments. And finally, you are going to avoid areas with lipidic plaques and eccentric plaques, and you are going to land in a very, very decent area. It is not about length and diameter. The landing is very, very critical. Compared to IVUS, I'm sure the OCT proponents will have a very, very comfortable area to land. In terms of diameter, again, the Japanese group promotes lumen-based, whereas Ziadali group promotes EL-based. But the critical point is when you select a landing zone in an area where the MLA is good, block burden is 0, you are going to bargain to the same. If it is lumen, you are going to add up 0.25. If it is an EL, you are going to downsize by 0.25, provided if you are going to select your landing zones in a plaque-free area, no vulnerable plaque with a beautiful MLA, then you are going to bargain both same. But the question comes, when there is non-detectable EL, where the problem comes, of course, in subsequent slides, I will take you through those areas. So basically, we need to select the stent based on the distal reference. If it is lumen-based, add 0.25 to 0.5, depending on the plaque. If it is EL-based, downsize by 0.25. When it comes to post-dilatation, you need to divide the stents into. Previously, when OCT was not available to us, we just take a 3 stent, we generally post-dilate 3.5 throughout. Now, in a stent of a longer length, anything more than 18 mm, we can divide the stents into 3 parts. You can get the EL in between. You can take a proximal reference, accordingly take a proximal dilatation balloon. Middle, you can take a different size balloon. Nowadays, I used to put a 3 stent of 38. I need to take a 3 balloons, 3 in the distal half, middle 3.25, in the proximal maybe 3.5. These kind of adjusted post-dilatation insight was got to us by OCT. So morphologic assessment was the key. When the morphology tells us it is a lipidic plaque, you need not do a preparation. If it is a fibrous plaque, just a general preparation. If it happens to be a calcific plaque, based on your score, either you have to do an atherectomy or other device. So basically, we need to look into the wall or in the lumen. If it is in the wall, if it is the light is able to pass through, then it is calcium. It will define the borders. If the light is not able to pass through, then it is a lipidic plaque. If it's in the lumen, if the light is able to pass through, then it is a white thrombus. The light is not able to pass through because of the high attenuation, then it is red thrombus. This is a clear example of where The light is being prevented by the shadow, which is in the lumen. It's a red thrombus. Here, the light is able to pass through and able to define the abnormal signal within the lumen, that is white thrombus. And having said about length assessment, Harish was making a mention about ioptica, where Ronnie Matthew was a principal investigator for the entire group. My site recruited 100 odd patients. Here, the key message was OCT with ACR it really helped us in terms of landing, particularly in terms of landing when OCT was not available to people without ACR. And these are all the ways one can avoid unsafe landings. Here is a case where there's an eccentric calcific block of more than one quadrant with an MLA of less than 4.5. You are going to have an edge dissection, you are going to have a malopposition, you are going to have a geographical miss. And then another area, the MLA is good, large lumen, but they have landed in an area where the proximal landing had a thin cap fibroathyroma, so either near future or immediately on table or in the future they can have a dissection. This is a safe area to land. MLA should be more than 4.5. The plaque burden should be less than 50%. There should not be a vulnerable block. This is a way to land. And this comes when the moment you decide in the proximal as well as in the distal landing, it is a normal or fibrotic vessel, you can go up your stent size by 0.25 to 0.5. Like here, it's shown in a distal reference 2.5, proximal it is 3.7. So they have went up by 0.5, distally 2.3, whereas in the other landing, they were able to approach the EL. So moment you pick up a landing in a normal area, you can go even as high as 0.5 mm higher. Whereas in an areas when you are picking up an eccentric calcium, like I was mentioning about, unfortunately, there was a question here, what I will do then diffuse disease? Based on a lumen or a EL, but you are picking up in an area where the plaque burden is huge or in an area where you are forced to land a lipidic plaque or in an eccentric calcium, I think better to do a non-aggressive upsizing, that is just 1-to-1 sizing to avoid edge dissections. So diameter assessment, we talked about EL versus lumen-based. Opinion trial was the one proposed by the Japanese group where the lumen-based approach resulted in comparison to IVUS, the stent expansion was lesser, whereas the Illumian 3 trial promotes EL-based measurements most of the time, and the EL is not available to us. Basically, you need to look into the lumen, which I was talking about, but landing, if you pick up in the right area, both will. So basically, the EL-based measurements was proposed by Illumian 3 and in Opinion trial compared to an IVUS. When lumen-based measurements was done, it was final expansion was lesser. Let me take you through. This is a post-stent. Basically, we need to look into dissection, apposition, expansion. I think we all know all these criteria for the want of time. Let me take you through one of my case. 67-year-old male admitted with chest pain, diabetes, hypertension, non-dominant RCA, dominant LCX looks good. Like K. Narajan's case, this LAD was looking to me intermediate. FFR was done, 0.77. Having done FFR, having proved that this has to be stented, next comes the imaging modality. The very purpose of doing imaging here, I am involving in an intermediate lesion in a diffusely diseased LAD. I need to know where I have to land. The automatic lumen profile automatically detects this proximal landing somewhere 2.81 automatic lumen. Similarly, in the distal also, automatic lumen is 2.86. It tells about the predilatation induced dissections, the luminal gain. The morphology automatically tells it's a fibrotic plaque predominantly, no much calcium, no much vulnerability in both ends, both landings. So it was 338 based on OCT because it was lumen, it was 2.8 somewhere, so it was upsized to 3 and post-dilated. Because why I took a 3.5 balloon post-dilatation, because I know from the OCT, the EL, my limit for post-dilatation on this particular artery is 3.5. This is a basic idea of in each vessel, knowing both your lumen as well as your EL. The lumen will tell you about your adjustments on stent sizing and upsizing it. Your vessel sizing will tell us what is your limit for your post-dilatation. So this is your post-stent optimization, I got an MSA of 5.26, no outflow disease, no inflow disease, no proximal or distal edge dissections. These are all automatically, quickly seen. One need not do big brainstorming to overall expansion is 99%. If someone is not convinced with overall, you can divide the stent into 3 halves. You give the reference. Accordingly, you can split it out your expansion indices. And this is the final angiogram. In a vessel diffusely diseased landing, sparing the osteoproximal angiographically without knowing what happened to the proximal edge. Now, OCT guided, proximally, I am very clear that I have landed in an area, there is no lipidic plaque, no eccentric plaque burden was less, no edge dissection. I am confident. I think this was talked about, Harish. For the want of time, I will just quickly take you through another case, a combination of OCT where it will be useful in both bifurcation and left main.
Because of, for the sake of time, if you don't mind, I think we should move on to the discussion now. It was a beautiful case. Any closing comments before we move on?
Yeah, I think with the currently available 3D OCT, whether it is simple cases or complex scenarios or left main bifurcation, apart from routine optimization based on MLD max algorithm, this is really going to give a lot of confidence in finishing a case with angiography alone. It's a mathematic, it just guides you in like an arithmetic so that you can confidently finish your case.
Thank you so much.